She had talked about some secondary side effects on the dabrafenib and trametinib treatments that cause squamous and basal cell. That lead to Dr. Trotter, who is going to go over some skin exam and some of that management of the side effects from the BRAF mutation medication.
Good morning. Can you hear me okay? Well, good morning. My name is Shannon Trotter. I'm a dermatologist. My background is I used to run the Melanoma Pigmented Lesion Clinic at the James. I'm now in private practice, and I also head up the dermatology residency program as an associate director for Ohio Health. But I'm here today to talk to you about more on the prevention side. So what I'd like to tackle this morning is the self-skin exam. You never know what you're going to find. And this has a double meaning because I want you to know what's out there about skin exams in general, and then what's the importance of a self-skin exam. Because just like other types of cancer, for skin cancer, having a patient that knows their skin and looks at their skin is very important. It's one of the things that makes skin cancer unique, if you think about it. For other types of cancer, we can't see necessarily what's going on inside the body. But often for skin cancer, you're going to be the first one to pick up on a change. Quickly, I do want to disclose that I do speak for a couple companies, Celgene, DUSA, and Pfizer. I'm also an investigator for cutaneous squamous cell carcinoma with Castle Biosciences. We're trying to develop a genomic profile for high-risk squamous cell, and I speak for them on behalf of that topic. So what do we accomplish today? We want to talk about what's going on with skin cancer screenings. What's the national setting? What do people really think about this? In particular, agencies that make decisions that impact how insurances cover it and how many other people perceive the value of skin cancer screenings. Next, we want to talk about how do you actually do a self-skin exam. So we have a short little video to show you. We thought about having somebody come up here and volunteer, but we thought that might be a little awkward in front of everyone. So we're going to show a short little clip, about 1.5 minutes, where you'll see how the Skin Cancer Foundation recommends that you complete a self-skin exam. After that, we're going to talk about some side effects that occur with BRAF inhibitors. Dr. Jeter already mentioned a couple. I'm going to mention some additional ones in addition to the skin cancer that was brought up, because there are some weird, kind of unusual things that can pop up on the skin, and talk briefly about how we can manage those as well. So for those of you that haven't heard me speak before, I love audience participation. It's a little restrictive for me having a camera because I can't move. I'm used to going back and forth and picking on people throughout the crowd. So the people in the back can't hide. So Feng has agreed to help me out today.
I'll be your Vanna one.
Yes, she's my Vanna. So the good news is you have a 50-50 shot. I tried to make these pretty simplistic and straightforward, and she has a little goodie bag for you volunteering to put yourself out there and guess one way or the other. So the first question, fact or fiction? The U.S. Preventive Services Task Force strongly supports the use of skin exams to help detect skin cancer.
You have to raise your hand.
And she'll pick you,
out.
yes.
I'll pick her since she's
Yes.
So the answer, she said, is yes.
Oh, fact.
And it's actually fiction.
Oh.
So a lot of people don't realize this. She still gets it, yes. You get it for the mere fact. I tell people there's reward in life. You put yourself out there, you still get reward. So this is fiction. So if you look at the U.S. Preventative Services Task Force, this group is actually made up mostly of volunteers. And there are physicians involved, there are PhDs, there are researchers. Predominantly the physicians are in the primary care field, if you will. But this task force is actually supported through Congress, if you will, with an agency that's on healthcare research and quality. So it's not a direct government, if you will, agency or task force, but it's kind of a side one that Congress does look to and the government does use for recommendations. But back in 2009, so we're going back a little bit, they released a statement that says there was not enough evidence currently to support actually using whole body skin exam or patient self-skin exams that they found of value. And this was something that really concerned us, even back at that time frame. There were a lot of criticisms about how this was done, how they looked at data. Data was only collected relatively short time frame, 1999 to 2005, and after 2005, there actually had been some other studies that supported the use of doing skin exams that was not included in their analysis at that time. The other criticisms, we know patients can detect their own skin cancer, but the value of going to your physician, in particular a dermatologist who is trained to identify skin cancer early on, is that we know physicians can detect earlier. And for skin cancer, that's very important, because often if we detect earlier, there's better outcomes for patients. Another criticism, Most patients don't perform self-skin exams. That's one fact I want you to take home today. I'll even ask when people come in, are you doing your self-skin exam? And I will get, well, maybe, or no, I rely on you to do it. And so that's one of the things we've noticed. It's just time like anything else. Life gets ahead of us. And this is even in folks that are high risk that tend not to perform self-skin exams. So we were trying to point out that there is some value. Now there was another release that came out back in 2015, so this was December, again, where the task force reevaluated the data. And again, they came up with a grade. If you look over here in this red circle, what this task force does is it grades data, A, B, C, D. They give it a grade, if you will, on how important or valuable it is to offer a recommendation. What they graded skin cancer screenings as is an I. An I actually stands for is that, again, there's insufficient evidence, and that, again, the balance of benefits and harms cannot be determined, okay? So you'll see that listed there. So that was a little frustrating for all of us, again, that a second review did not garner support. And we do feel like there is support and value in doing this. So we did a rebuttal. And on this, I know for you as far back in the room, you'll see this title, Skin Cancer Screening, Recommendations for Data-Driven Screening Guidelines, and a review of the U.S. Preventive Services Task Force controversy. This article, although you can't see in the background, has several of us, so you might see down here below, that actually participated in this rebuttal. So you'll see Dr. Jeter, you'll see Dr. Kendra, you'll see myself, you'll see Dr. Bill Carson. So there's a strong presence from Columbus and the community here to fight against that recommendation for there being insufficient evidence for that. And I think that's what we're trying to continue to do. We're building an argument based on fact, evidence-based medicine that we hope eventually will overturn those recommendations. And that does have implications because that does impact if insurance wants to cover things. This is a task force that says whether or not screening is valuable. And a lot of people question, again, the data and the process, and that's what we're doing, hoping that they will overturn this and grade this with sufficient evidence that we will then recommend skin cancer screenings for people. So next question, fact or fiction? All insurances cover a skin cancer screening performed by your doctor.
Okay, I'm going to go all the way to the back.
Fiction, she says. And she's right. So I want to talk about the definition of screening. So I have it up here on the board, screening. When you have no evidence that you actually have a disease, but you get the test. So screening tests we're all very familiar with. Women will go and get a mammogram. There's no evidence even that you may have breast cancer at that point, but it's recommended at a certain age and certain interval that you get a mammogram to screen you for it. Or some of us get a colon cancer screening. We go for a colonoscopy. Again, there's no evidence at the time that you particularly have colon cancer, but they screen you for it. They are looking for it. For a lot of insurances, they don't typically cover a skin cancer screening unless you're considered very high risk. You already carry a diagnosis of melanoma. You may have a diagnosis of another skin cancer. So if a person came in, maybe 45 years of age, and said, I just feel like I need a skin check, I'm concerned maybe I had some sun exposure in my past or a burn, some insurances may not cover that because they don't feel like it's valuable. And it goes back again to the recommendations by that task force because again, they're evaluating evidence to support whether or not we should do that. That being said, often people do get skin cancer screenings because they're coming in for multiple lesions they're worried about, and we wind up looking at the entire body. And of course, if you carry a diagnosis of skin cancer, we're going to perform that screening. Keep in mind the ACA, so the Affordable Care Act, actually doesn't include those either as covered if you're not high risk in that group. And then surprisingly enough, if you look at the American Cancer Society, they don't recommend blanket screenings either, which surprises some people. So I put it up there. Again, they're looking at the evidence. They're a national organization with local outreach, and they're looking at the evidence bodies that are presented by the task force and other groups. And right now, currently, they don't recommend that blanket screening. As a dermatologist, we do this often. Every May, we offer free skin cancer screenings. We don't care if you've had a family history of melanoma, or if you've already had melanoma or skin cancer, or if you're just somebody who comes off the street. We will screen you because we know there's value. Not only for melanoma with early detection and hopefully improving outcomes because we know melanoma is a deadly skin cancer, but also for non-melanoma skin cancer too, because some of those can progress. And although not common, there are instances where those cancers can spread and become more aggressive. And then there's cost to the healthcare system to treat those, and there are also complications from surgeries that sometimes we really don't think about. So next question, fact or fiction? Self-skin exams are an important part of your care because if a skin cancer is detected early, it can often be cured. Fact, you got it. So again, the majority of skin cancers are what we call non-melanoma skin cancers. They're not melanoma. Melanoma accounts, you'll see some different reports, anywhere from 1 to 5% of all skin cancers. But the majority of skin cancers are basal cell carcinoma or squamous cell carcinoma. And then there are some other very rare skin cancers within that group of skin cancer as a whole. Basal cell carcinoma is the most common, followed by squamous cell. And typically, the good news, we can cure these, like Dr. Jeter said, typically by surgery alone. There are instances, though, where these can be more aggressive, especially in a patient who's immunocompromised. They may be a transplant patient. Also, patients who carry a diagnosis of leukemia or lymphoma at times are at high risk for more aggressive skin cancers, too. But we know to look for the early warning signs of skin cancer. So when you do a self-skin exam, we always talk about the ABCDEs of melanoma, which I'll revisit again today, because sometimes that's confusing. And I will talk a little bit about just understanding your baseline, because that's actually the most effective thing you can do in looking for a change from baseline in your skin. Other skin cancers can present in a variety of ways. New growths. I tell folks, usually by the age of mid-40s to even late 40s, you should not be getting true new moles. If you have a growth you think is a mole that is new, that should definitely be evaluated. It's a little bit more challenging through teenage years, 20s and 30s, because new moles are continuing to evolve and grow over time. If you have a sore on your skin that doesn't heal, you definitely want to let somebody know. Something that doesn't heal on the skin can definitely be a sign of a skin cancer. You can also have skin cancers present like warty growths. They look like warts. Squamous cell carcinoma has been linked to the wart virus, known as HPV, or the human papilloma virus. So I always tell people, you always want us to check those out and make sure that it's either a wart or potentially it could be something more concerning. In addition, some skin cancers present like little peak scaly rashes. They can look like ringworm. And people are shocked when they come in because they had no idea. They just thought they had some eczema. They had some ringworm, and it's been sitting there for several years. Early skin cancer, both basal cell and squamous cell carcinoma, can look like a little pink patch, and rarely also can amelanotic melanoma. So the next slide here, I'll show you what we call the ABCDEs of melanoma. So you guys have probably heard this a lot, I'm guessing, right? So what does the A stand for? Asymmetry. You guys can cheat, it's on the board too. So, asymmetry, what does that mean? It means the left and the right don't look the same, or the top and the bottom don't look the same. What I tell people is think about you want a pizza pie like that you order from Domino's or Pizza Hut. It's a nice round circle, and if they've done a good job on the toppings, there's an even distribution. So if you cut it top to bottom or side to side, it would look symmetric. In this lesion here on the right, you can see if I cut it top to bottom or side to side, it's asymmetric. You can't really mirror image either side on top of each other. B stands for border. So borders, do we want borders to be smooth or curvy for normal lesions? Smooth, right. So in this instance here, you'll see how it's curvy. It resembles a cloud in the sky. Next is color. We want our moles to be all the same color if we can. Some people do grow some variations of moles of color, and they may even grow what we call atypical or dysplastic moles as well. But coloring in general, we want to be homogeneous or the same throughout. And I tell people it's kind of like if you have a chocolate chip cookie. You probably have had the disappointment if you ever bitten into one and you thought it was chocolate chip and it was raisin. Anyone have that happen? Yes. So a chocolate chip cookie, you assume if somebody's done a good job, there's even distribution of the chocolate chips all throughout. So every time you take a nice bite, you get a nice bite of chocolate chip cookie and the actual part of the dough part of the cookie. So when we look at color, you want color to be nice and even all the way throughout. You don't want it to be irregular in different spots. And you'll see here in the diagram, there's different colors. There's shades of brown, tan, dark brown, even a little pink or red. And that can sometimes occur. For our diameter, size counts for moles. We typically recommend that moles are less than 6 millimeters or the size of an eraser on the end of a pencil. So when you look at the size of one of your lesions, it's something of concern potentially. But some people grow large moles as well. And then E stands for evolving. If any of the moles you've carried most of your lifetime start to change or evolve, where they're changing in color, they're changing in size, they're changing in shape, or the borders are becoming more curvy, that's something to remember. And I think that's actually the most important feature, because some people do grow some slightly irregular looking moles. That's just them. They grow dysplastic or atypical looking moles. And that's a normal for them. But if that mole's always been a little hazy and maybe had 2 shades of brown, and all of a sudden it's really hazy and now has a new area of dark brown, that would be a change from baseline. That would be evolution, and that could potentially be concerning. So here's an example clinically of a basal cell carcinoma. A lot of people are like, but wait a minute, what's this up here? Does anyone know what this is? You may have some on your skin or been pointed out to you before. Does barnacle or wisdom spot ring a bell? I figure you're gonna know. She's got it. Seborrheic keratosis. So this is actually why the patient came in. They said, I've got this terrible lesion behind my ear, and they were worried about it. That's a nice kind of way we tell folks of saying you have a wisdom spot. These are benign growths called seborrheic keratoses. They tend to run in families. There's really no direct correlation with sun exposure or anything the patient did to cause them, but these are a natural change of the skin over time. Just south of it is the lesion I was concerned about, this pink pearly little bump. It was new, and that's a classic lesion of a basal cell carcinoma, where it has that kind of pearlescence and shininess to it, sometimes some crusting as well. Next image here. This patient came in and was actually on a BRAF inhibitor. And she presented with this lesion. It just sprung up quickly over a period of about 4 to 6 weeks. This is a classic example of a keratoacanthoma, which people classify typically as a type of squamous cell carcinoma. How they actually grow over time is very quick. They erupt almost like a volcano type lesion, and it will scare the pants off folks because they had nothing there, and then all of a sudden this spot has just erupted. The good news is these types of skin cancer are not very aggressive, even though they quickly grow locally. Again, you can typically cure this by surgery. There are some people that will also inject these with methotrexate for treatment as well. So there's a whole variety of treatments, but it can be quite daunting when this comes up completely out of the blue. So fact or fiction? The Skin Cancer Foundation recommends that self-skin exams should be performed monthly.
I'm going to go all the way to the back.
You're going to play it? Okay. Fact. She's exactly right. And this is where we have a short little video clip that we're going to play, and it'll show you again how to do a self-skin check in about 1 minute and 30 seconds. There's a blow up on the right. If you blow the screen up on the right, yeah. Well, you'll see here, if we don't get sound, she's saying you need good lighting, a full-length mirror. Is everybody what's coming on?
Just follow the images.
Can you go back and replay it, and I'll comment on it from the beginning. I'll give a little commentary, so unfortunately we can't get sound. This is available online, so it's in your packet. So if you feel like you want to review it, feel free to do so. Yes, if you don't mind to beginning, and I'll just kind of briefly comment. So this is talking about doing a self-skin exam, which we recommend doing monthly. That's typically what's recommended, just like you would do a breast self-exam or you would do another screening at home.
Oh, I know why. I have the volume turned off.
Okay, no worries. So again, you can review this at home. I'll kind of commentate because I know this video pretty well. What she's going over is a recommendation to do it each month. And then what will you need to do it? Good lighting, a full-length mirror, a handheld mirror, and often we'll recommend a chair or a stool. We'll recommend first checking the face, neck, and upper torso, looking in the mirror. And you can look at either sides, even behind the ears, and the frontal scalp line as well. Then we recommend checking the arms, armpits, and the hands, raising your arms up and using a mirror to help guide you too. Next, you'll check the lower torso, and you'll see here kind of looking below. You can move around areas of the body if it's difficult to see, followed by checking the legs and feet as well. When you check the legs and feet, make sure you look at the inner thigh and in between the toes and the bottom of the feet too. And then check the back half. That's usually using a mirror, a handheld, and then a mirror behind you. Or more importantly, I think having a partner help you is quite valuable. And they can be looking for signs of any changes or new lesions. In addition to what they show you here, we recommend again once a month. I also recommend too that you have somebody comb through your hair to look at your scalp, that you look at your eyelids, you close one eye and the other to make sure you don't see anything around the eyelids. You even take a peek inside your mouth. So if you can walk up to your bathroom mirror and say ah and stick out your tongue, move your tongue side to side, you can get skin cancer inside the mouth, both melanoma and squamous cell carcinoma. Dentists are good at screening for that. And then the other thing I would recommend that they don't really show, mostly just for privacy, is to definitely check the private area. So look around. For women, that includes inside what you can see of the vaginal area, and for men, definitely around the scrotum and the penis. And then if somebody can help you, even around the anus or on the backside, in between the cheeks. Skin cancers, yes, are caused by excessive sun exposure and UV light, but not all skin cancers are caused by that. Sometimes other things happen in the skin. Errors occur in that DNA or mutations occur that aren't triggered by sun exposure. So to be exceptionally thorough, we recommend looking all over those parts. And lastly, don't forget your nails. That's one of the things they don't include in that. You can get melanoma or squamous cell carcinoma in the nail or the nail bed. So you always are looking for changes in your nails as well. And if you're a chronic nail polish user, make sure you check that too. So fact or fiction? If you are undergoing treatment with a BRAF inhibitor, it is important to perform self-skin exams. This is the last one. She's got it. True. That's right. You got it. So it's fact. That's a good kind of like, you can waver in between and try to get that. I like that. I like that. So yes, so BRAF inhibitors, talking about vemurafenib as well as dabrafenib. BRAF inhibitors side effects. For the skin, there are a lot. And you'll see several here listed, not an all-inclusive list, but probably the most common things that I had seen clinically when patients were coming through the office. The big thing, especially when vemurafenib came out, was photosensitivity. People could easily burn while on this medication. So we were really promoting, sun protection in the beginning, obviously, if they're already on it. But in addition, now with that medication, it can make it much more severe. We also will see warts or even warty-like lesions on the skin. And that's one of the things I tell folks is pretty common to get. And then in addition to that, rashes. And there can be a whole host of different rashes that occur. Dry, itchy skin. You can have what we call a maculopapular rash that can occur, even up to the extent of severe drug reactions. There's one called DRESS that has sometimes occurred on this too. So there's a whole spectrum of rashes that may develop while on therapy. The big thing that we have highlighted here is the types of skin cancers that can develop: squamous cell carcinoma, basal cell carcinoma, and new primary melanomas. For squamous cell carcinoma, the most common, about 24% of people, a little over that, developed it in clinical trials. Typically that was associated with age greater than 65. Chronic sun exposure as well was another risk factor for this. And median onset was around 7 to 8 weeks. So for a lot of folks that are undergoing this therapy, the recommendation, the package insert, and consensus is to actually do skin exams around every 2 months to make sure we're diligent at catching this. New primary melanomas, a little over 2%. If you could read, especially for vemurafenib and the package insert. Again, screening more frequent for those patients. I had 2 patients that were on to develop melanoma in situ. That was new for them when they were on therapy. And basal cell carcinoma as well. So again, we're screening for those types of skin cancer to catch them early. The reality is we don't know necessarily if squamous cells in particular are in this drug. Would they potentially be more aggressive? Hard to say. We're definitely screening people very early on and catching them. So if we left them, it's hard to say what impact would the drug have on the outcome of that squamous cell carcinoma. And then lastly, a common thing that I saw, believe it or not, is nipple hyperkeratosis or thickening. And I'll show you a picture of that too. So this is a picture here of somebody's back. And you can see here, they have a lot of these lesions, which are just like what I showed you before, that really dark growth. These are variations of a seborrheic keratosis on their back. And this was something that was new. You can see it's slightly different, maybe a little rim of redness around the base, a little white crusting. So it looks a little different, sort of sticks out from the other lesions on their back. And this was actually a squamous cell carcinoma that developed when they were on vemurafenib. This rash here, some of you may even have this already. Anyone's back of their arms look like this? I've actually got it myself. Other people may have it and not even realize it. This is a common rash called keratosis pilaris. It's actually usually inherited One parent typically has it. Children have about a 50% chance of getting it. When you're on BRAF inhibitors, it can actually develop spontaneously and more diffusely. It can include the arms, the legs. I've seen it career across the abdomen, even the back as well. It is a harmless rash, but more of a frustrating one. You can get redness around where the little hair follicles are, as you can see here, and then you can get little kind of spines, people call it, or they may even pick at them if some of you have it in the room, where again, the skin cells don't shed sort of normally, and it builds up these little kind of spines in the skin. Very treatable. We use lotions that basically exfoliate the skin and help with this during therapy. This is an example of sun sensitivity. You can see here she had a curved or kind of collar on that protected her here. You'll see here some sparing of the chin underneath because her chin serves as a shade to protect her here, and you'll see she got a little bit of redness here. This is a photosensitivity reaction or sunburn reaction because she was out in the sun while on drug. This is an example to orient you here, the nipple on the chest, and this is where you have thickening of the skin or that hyperkeratosis. Again, we can use lotions to improve that texture and look. And then here's a wart as well. Again, this looks more classic for warts, so typically would be directly treated. If we're ever in doubt, is it truly a wart versus squamous cell, we will choose to biopsy. So in summary, while not mandatory to be covered necessarily by insurance at this stage of the game, skin exams help detect skin cancer early on. And that's why they're so important, especially because we know we can have better outcomes for patients if they're detected early. Skin exams are especially important for patients if they are undergoing BRAF therapy because of the development of new skin cancers, both basal cell, squamous cell, and melanoma as well. And then finally, we recommend you should definitely perform a self-skin exam. You are going to be the first detector often of some change on your skin. And what's important is you really just know what's normal for you. What's your baseline? Because you could just be a very moly person, and the person sitting next to you could hardly have any moles. So it's just important to know that this is normal for me and that you look for a change from baseline, and that can help kind of aid your doctor in the diagnosis of a skin cancer. And then before I take a couple questions, I may have a couple minutes because we just had about 5 left. If you are interested, the Ohio Dermatological Association is holding an advocacy day, Wednesday, May 16th. At this advocacy day, we are going to be reintroducing or trying to get support for the reintroduction of a tanning legislation bill here to ban tanning below the age of 18. For those of you that don't know, Ohio was one of the first to propose it, and we're still one of the last to get it passed. So we are actually meeting with legislators. If you or someone you know thinks they were affected by tanning, especially under the age of 18 or even in the early 20s, and developed melanoma or skin cancer, the legislators want to hear from you. It's different for me to come in and tell them I had patients where this has happened, but it's quite a great experience. You get to go to the State House, you get to meet with them and tell them your story, and really see the impact that tanning beds have on our younger generation. So if any of you are interested in participating in that, Jill Hostetler, who's our executive director, her email is up there. Feel free to outreach to her. We would greatly appreciate your support in our battle against skin cancer. Thank you.